Thanks very much, Robert, for the introduction. And it's fantastic to be here this morning. Really excited. Also a bit mixed feelings, as you say. It's my farewell lecture, so it's good and bad at the same time. For today, having been an attendee here the last 2.5 years, I tried to come up with something a bit special as my farewell lecture. And I hope you're all going to enjoy it. The first time I stood here was in 2012 when I came over for the Groin Pain Center. And then, as you said, Robert, I joined at the start of 2013. And I think when you join here as a sport physician, you really feel like you're joining a special team. And also as a sport physician, I was part of the Sports Groin Pain Center. And the Sports Groin Pain Center, it's not a building or a room, it's a team of people. And it's a really unique team. And that unique team, I think, has done unique work while I've been here. We've done, I think, some really good research, and today's about showcasing that. So I was thinking a little bit about really cool teams and cool people, and then it came into my head, that's like the X-Men. So that's a little bit the theme of today, is the X-Men. So the theme of the talk is the entities. And like all good movies, we should start with a trailer. So I give you the X-Men. Thanks. So I hope I got you in the mood a little bit, ready for the next half an hour. The way the talk's built, I'm going to take you one by one and introduce you to the members of the team, talk to you about the work they've been doing over the last 3 years or so, then talk to you about the clinical relevance. Why is it important? When I go back to Holland, people ask me, what did you learn in Aspetar? These are, for me, some of the many highlights of the stuff that I've learned while I've been here. So share that with you. Why is the research important? And then today I don't always or only want to look backwards, also look forwards. What's the important issues that we haven't resolved, and how can we as Sports Groin Pain Center move the field forward? So every team has a professor, and we have our leader and professor, aka Per Holmik from Denmark. Now Per has been working on the groin for more than 20 years, and I think when he goes to bed at night he puts on his professor helmet and he's dreaming of groins. And in 1997 already he wrote his first paper describing adductor-related groin pain. So the idea that you can classify groin injuries according to clinical findings and recognizable clinical patterns. I think when I was working in the UK, Holland, and then you come here, you see how confusing the field of groin pain is. People are using all different kinds of terminology, and this causes a big problem. Robert, you mentioned already we had the conference last year in November, which was fantastic. And around the conference, because we were inviting a lot of different experts, we also held an agreement meeting on terminology and definitions in groin pain in athletes. And this meeting, we had 24 experts attending. And I think if you look at the picture, it's quite easy to see who plays football, because you ask them to line up like this, and then look again, and you can find the ones who have a football background. Before the meeting, I sent out 2 cases to the 23 other experts in the group. They're simple, everyday clinical cases. And I asked them, which term would you use to describe the diagnosis? So a simple case, which term would you use? They could give as many terms as they liked. And this, we've published this in this month's British Journal of Sport Medicine, which is also a nice farewell gift. We have the Aspetar on the front cover and a whole series of papers. The majority of the papers that I'll present today are all contained within this issue. And thanks to Aspetar, the majority are also open access, so we're able to share our work with the wider sport medicine community. So we had 23 experts. The first diagnosis, 23 experts and 18 different terms used to describe the diagnosis. And for the second case, 23 experts and 22 different terms used to describe the diagnosis. So for me and for us, I think this really highlighted the need to have a meeting like this, what a mess the field has got into. So we were looking at trying to establish a common language. We had sports physicians, sports physiotherapists, orthopedic surgeons, general surgeons, radiology, all represented at the meeting to try and get people from different clinical backgrounds and also people from different geographical regions. Why is it important to have a common language? I think if we're looking after athletes and we're not thinking and doing the same thing well coordinated, you can get in a bit of a mess. So that's what it was about. Can we establish a common language? So we met for the day. It was a really good meeting, an agreeable session. And I'm happy to say we published this on the 1st of June. You'll see in red how many Aspetar-owned stuff are on this paper, so I'm very proud of that and to have been part of the team that put this together. We defined 4 clinical entities: adductor-related, iliopsoas-related, inguinal-related, and pubic-related groin pain. We discussed the hip as an important cause to consider for groin pain in athletes, and we discussed other causes because we know the groin has a broad differential diagnosis. Now I know here that not all of you in the audience are clinicians dealing with athletes with groin pain on a day-to-day basis, so I didn't want to go into this in massive detail, but the 4 entities are summarized, I think, quite nicely in this picture, and I would encourage all of you who are involved in the day-to-day care of these athletes to go. It's an open access paper you see in the top corner. Download and have a look at this so that we, as the Aspetar community, can start to use this common language to avoid the confusion that happens when we don't. Looking to the future, it's not like we've solved all the problems with this. I think we just established a framework of well-defined terminology that will allow us to move it forwards. There's a lot of work still to be done. Can we reliably classify using this system? What's the underlying pathology? These are just sets of clinical signs and symptoms. We need to perhaps use imaging and other things to establish what's going on at the tissue level, what's the actual structural problem. And I'll come back to that later because there's some great plans surrounding this already started. Entities often coexist. You can have adductor and inguinal related groin pain. How would we deal with that in clinical practice? What's the best way to treat when these entities combine, which is extremely common? So it's not like we finished the issue yet. I think some very important work still to be done. The next member of the team, our Australian ex-Ray woman, aka Andrea. You're probably used to seeing her walking around the screening department armed with a goniometer and asking the athletes to push, push, push when she's testing their strength. In her spare time, and I know because we did the boxing classes together, she's got a fantastic left hook. But her superpower, what you might not know, and it's very useful when you want to do a screening PhD, is that she can actually look inside the footballers of the Qatar Stars League and find out about the morphology, the shape of their hip joints. So Andrea's doing her PhD on screening, and this is the setup of her study. So the first thing, a systematic review looking which factors can differentiate athletes with and without hip or groin pain, and her main study looking at screening and a risk factor study, and I'll just take you through these one by one. So a nice proud moment for Andrea, published her first systematic review in the BJSM. She went through 17 papers, and we found strong evidence that the bent knee fallout, the hip internal rotation test, and pain and reduced strength on adductor squeeze testing can differentiate those with and those without groin pain. So this in part formed the basis for the screening part. She, together with the team in rehabilitation, has screened the footballers from the Qatar Stars League last season and this season before they started playing. They had a full screening with a number of different tests that I'll show you some of them in a minute. Those that consented also had an X-ray of the pelvis and both of the hips. And then, with the help of Dr. Cristiano and the team from the NSMP, this will be linked to the injuries that they've had over the last 2 seasons. And this forms the basis for a fantastic study that's highly relevant, I think, to clinical practice here. The clinical assessment, they were checked for the presence of pain, the flexibility tests, and a series of strength tests, and they also performed the functional movement screen. And this has already generated normal data. And this is really useful for us in clinical practice, because now, for example, we know that your adductors, which are commonly injured in the groin on the inside, should be 1.2 times as strong as your abductors. So if we're screening players and you're down here on the bottom left-hand side, we might be worried that they're not strong enough for football. If you're rehabbing players and you want to get them back to a normal level of strength to play football here in Qatar, we've now got something to aim for. There's no side-to-side difference. That's also clinically relevant, because you can also try and get them back to the other side. So this normal data, Andrea's writing it up now for another paper, is highly relevant to both screening but also rehabilitation of injured players. As I said, she did X-rays, and one of the things we've been looking at on the X-rays is the presence of a cam lesion. For those of you who haven't heard it before, the hip, it's a ball and a socket joint, and ideally the ball should be round, it should be spherical. Sometimes players develop this, a bump, on the ball side of the hip joint, on the femur side, and this cam may go on to cause problems because it kind of jams into the joint as they rotate. More than 400 X-rays have been performed on the football players, so we have a fantastic set of data there. And to help us look at the data, we brought in an expert to look at the morphology, Rintje Agricola from Holland, who did his own PhD on cam lesions in the Football Academy of Feyenoord. And so Rintje and Andrea have been through all these X-rays and looked at the shape of the hip. Here's an example of how they've done the analysis. Here we see a round spherical hip. And here we see a hip where it's not spherical and you have this large cam lesion sticking out the side. And this has already given us some data on how common these lesions are in our population here. We see that 40% of the footballers have a normal shaped head of the femur, 60% have a cam lesion, and 23% have a large cam lesion. So this is important moving forward. We know if you do an X-ray to exclude bony pathology, 60% of the football players here you'll find a cam in them. moving forward, I think there's some fantastic work due to come out this year. We also want to look at the symphysis. We see a lot of abnormalities of the symphysis on these baseline X-rays of asymptomatic players. Is this related to pain or function in any way? Do the clinical findings, if you have this CAM, does this mean that your hip joint is stiffer? And we'll be looking at this as a paper also on the way on this. Are there ethnical differences? I think in clinical practice here, it's been remarkable how few hip cases we've seen in the groin clinic. And I have the idea that the labral tear here is much less common. And we have the unique opportunity here. Nearly all the papers published until now have been on Caucasian populations. We have a large Arabic and a large black population. So we'll be able to look, is the morphology the same, or are we seeing something different? And the main paper, a bit like the Daddio paper, is going to be at the end of the year. And that's, are these findings, the clinical findings or the X-ray findings, predictive of injury? So as the players go off and play, is any of this helping us to sort out who is at a higher risk of getting injury or not? The next member of the team, our very own Danish Thor, aka Andreas. And whenever you hurt your groin, you can just call him and he'll come running straight down to OPD with his machines to test your strength. In his spare time, he likes playing Australian rules football, which has led in the last 2.5 years since I met him to him tearing virtually every muscle in his body. So he's had a lot of experience with injuries also firsthand. Now, Andreas's PhD, that's on acute groin injuries. Like Andrea, he's also performed a systematic review. And I'll just take you through that briefly. So we spent the Ramadan last year scoring 72 papers, a methodological score. We found of the 72 that there's 4 high-quality studies and only 3 randomized controlled trials in the entire field until now. We also found that if you have a worse methods to your paper, the results, the success percentage is important, is better. So a worse methods in the paper leads to a better published results. And I think this is highly clinically relevant when we're talking about informing clinical decision making. And just give you an example of why this is relevant from a couple of studies that I was involved in as part of my PhD. So in Holland, some people are using this very painful manipulation of the adductors, they're called the Van den Akker method. And we studied this in a retrospective case series. And if you study it like that, the success percentage is 90%. And based on this, we set up a prospective randomized control trial. And the success percentage is 50%. So this is important to bear in mind when you read case series or publish literature with a very high reported success. Always scrutinize the methodology, because this is important. The main part of Andreas's PhD has been on acute groin injuries. Why is that important? If you type this into PubMed, until now, only 2 papers looking at the entire field of acute groin injuries. While the groin is one of the top 4 injuries in football, it's remarkably underrepresented out there in the literature and in our knowledge. So, Andreas's study involves looking at all male athletes who attended Aspetar to the outpatients with acute groin pain, onset less than 1 week old. They underwent history, a structured physical examination, and imaging. And whenever it was possible, whenever the event had been recorded, Andreas has chased down and got hold of the video with the help of many people. And this has led to getting some fantastic data. And I'll just first show you some of the video footage.
بنجم الكرة السعودية ومحللنا
Now watch the goalkeeper.
أفضل من أنجبتهم الملاعب العربية والآسيوية في تاريخها الكبير نواف التميار. نواف التميار لاعب كان يلعب بالقدمين بنفس الطريقة
prior to this match.
وبنفس القوة بنفس القدمين.
But the first two goalkeepers from the club were also unable to play. So he chose to play, went to do the save, and then hurt his groin much worse. Yes, here we see the Al-Waqqa team coming onto the pitch to assess him.
ومان سيتي من مدينة بار عمليا لواقع أقدام اللاعب.
And here you see him reach down towards his groin as he runs over to pick up the ball. That was the end of the match for him.
وسيظل اسم.
And so he was brought into the outpatients department. We did the history, the structured clinical examination, and we also did an MRI scan on him. And what you see on the MRI scan, this is his pelvis at the front, so we're looking like this. This is his pubic bones, and these are his adductors. And what you can see is this is the adductor, the insertion of the adductor, and this is the bone. And this is blood in between. So he's actually avulsed the adductor there, pulled it off completely. And again on this one, this is now an axial sequence. So we're going through him like this. The pubic bone. Here's the proximal tendon of the adductor. And this white in between, this is blood. So he had a complete avulsion of the adductors from the bone. And with the data like this, we've been able to gather a lot of cases, and Andreas has published his first paper in the American Journal of Sport Medicine this month, looking at 110 cases that came in through OPD. What we see here in Aspetar, 76% of the acute groin injuries are in the football codes. If you're a football player, 40% of the acute groin injuries happen during kicking. 2/3 of the groin injuries are in the adductors when they're acute, and 90% of acute adductor injuries are in the adductor longus. Also, 25% of acute groin injuries are imaging negative. So, again, really relevant and interesting data for clinical practice here at Aspetar. Also interesting is that there's sometimes a discrepancy between the clinical diagnosis, so the sport medicine physicians made a clinical diagnosis and compared this to the location on radiology. When you make a clinical diagnosis of the adductors, it's very rare that the actual injury will be in another location. But when we're talking about the iliopsoas or the proximal rectus femoris, in more than 1/3 of the cases, the clinical diagnosis and the radiological location of the injury don't match up. Why might this be? I think the adductors are superficial, and we can be clinically confident about the injuries there. And then if we look at the front of the hip, where the hip flexors are located, it's perhaps deeper, perhaps the pain's more extensive. But this is important to bear in mind when assessing athletes with acute onset of groin pain in the front of the groin. Again, lots of work still to be done. As the amount of cases grow, then Andreas will be able to start looking about which factors predict the prognosis. Is that clinical finding, location, imaging? What can help us make an accurate prediction of when the athlete's ready to return to play? What's the role of imaging? X-ray, ultrasound, MRI, these are things that we'll be able to tease apart. The main body of the PhD is Andreas's treatment study, where he's included more than 60 athletes who followed a structured rehabilitation program here at Aspetar. So we'll have fantastic data on the expected outcome of the rehabilitation to be able to properly inform decision making at the start. And as you saw, there's only 2 papers on this until now. So I think Aspetar here has a real opportunity to be a leader in this field with the setup that we have, all the acute injuries coming through outpatients. I see acute groin injuries as a fantastic opportunity to develop a unique knowledge set. What happened to the goalie? He did rehabilitation here in Aspetar. Here he is in action. He went back to the club after 67 days. And then worked his way back into training. And we see him here in action in his full flow. That one didn't go so well. There we are. So he did very well and still doing very well. The next member of the team, Elastic Man, our colleague Dr. Zarko from Serbia. You'll find him normally in the OR repairing groins or in the groin clinic together with me on Monday afternoons, where we've worked together since 2013. In his spare time, he likes playing a whole host of sports, and his other alias is Zarkopedia because he has a freaky ability to remember every sport result from history ever, which is in fact incredibly useful in clinical practice when you work with athletes. He can really speak the language because he knows what happened Red Star Belgrade in 1983 if he meets a Serbian football player, etc. So that knowledge really comes nicely together with his clinical skills. I learned about collagen from Zarko, and that's good for him because he's developed the ability to extend his finger far into the inguinal canal to reach places that others can't. So talking about our Elastic Man, going to talk about inguinal related groin pain, and we're honored today to have a German visiting super surgeon with us today, Dr. Muschewek from Munich, who's one of the most experienced clinicians in the world when it comes to inguinal related groin pain. We're talking about the inguinal region, so down in this area here, and Dr. Muschewek has described the fact that the deepest layer, your abdominal wall is made up of different layers, that the deepest layer can develop a bulge, so a weakness of this deepest layer, and this, the transversalis fascia, and that this can push on the nerve and give you pain in the groin. So when I was thinking about this and what could be wrong in inguinal related groin pain, I'm a sports physician, so I was thinking about tendinopathy or tendon degeneration. You have a normal tendon that's made up of fibers, looks like the fibers in a rope, and through overload or sport, tendons can degenerate and become disorganized, a bit like an untwisted rope. And then talking to Zarko, he's got the background general surgery and hernias. And in general surgery, well, they speak about collagen. And there are more than 20 sorts of collagen. And in hernia world, they're very interested in collagen 1 and collagen 3. Collagen 1 is the stronger type of collagen, and collagen 3 is a weaker type of collagen that's more involved in wound healing. And what's found in people who have an actual inguinal hernia is that there's an altered ratio. They have less collagen 1 and more collagen 3. So this raises the question, is this inguinal related groin pain, is this due to a tendinopathy or a degeneration through overload? Or do athletes who get this actually have a kind of collagen deficiency? And this is where I think also we have a fantastic opportunity to study this. And Zarko's been working together with Dr. Riboul, our visiting surgeon from France, aka Le Wolverine, and they're going to go in Bordeaux and take some samples of tissue from the athletes while they have surgery, and look at this together with Alex Scott, an expert histologist in Canada, and look, is this collagen deficiency or is this tendinopathy? So a fantastic study that could really put Aspetar on the map with regard to trying to get to the bottom of what's going on in this condition. There's more members of the team. The tag team from sports physiotherapy. I think it's good for Sean and Damien that they're not to be found on Google when you Google their names, But for Roald and Philip, the team of, otherwise they'd be dressed in pink lycra as well, but the team of sports physiotherapists who've been rotating and working with us in the Groin clinic, it's been fantastic working together with you guys. I've learned a lot about many aspects of rehabilitation. If I look at what I've learned here about clinical pearls to take home, that's that conservative treatment can work for inguinal-related groin pain. We see that every week in clinical practice. But as of yet, it's still a challenge to know when it can work, who it will work on, and how long does it take to work. And to this end, Roald has designed and started the inguinal-related groin pain rehabilitation study here at Aspetar, and he looks pretty happy about it when he's doing his exercises. So this involves the athletes being referred from the groin clinic and then following a phase and criteria-based structured rehab program here at Aspetar until they either recover, which we hope, or not. And this will allow us to find out when it's a good idea to do rehabilitation, when should we consider surgery. And there are already 3 patients in this study, so I really look forward to the future there as well. Another member of the team, Megamind from Australia, aka Rod, who's also the one who taught me how to mess around in PowerPoint, so it's all his fault. But I think Rod was born with some extra chips somewhere up there, and also a mean curveball. He seems to have the uncanny ability to read every paper ever published on PubMed. And I think in his garage he's building a biomechanical android robot that's going to solve everything. So Rod, I've learned a lot from you as well in the time here. And one of the most interesting things for me has been about pubic apophysitis. This is work that's been done with Mathieu Sailly, who was here before in the Aspire Academy, and Amanda, who's here today as well. Congratulations, guys, on publishing this, because I think this is a very important paper. We have all heard, I think, of the Osgood-Schlatter, growing pain in the knee, or the Sever's disease, growing pain in your heel. Does this exist in the groin? Now, if we look at an X-ray of the pelvis, and again, we're going to make a scan and go through this, the front of the pelvic bone, and look at this axially on a CT scan. And here we can see 3A. That's a normal, and this is the front of that symphyseal joint, and here we see it's like this. And in 1 and 2, it looks different. So in 1, it's kind of curved and a bit fuzzy, and in 2, we can see these small pieces of bone. These aren't loose bones, this is the ossification center. So in 1, there's a growth plate at the front of the pubic symphysis that doesn't yet contain any mature bone. In number 2, that growth plate is starting to ossify and become solid bone. And in 3A or 3B, that's matured and connected with each other, just like what happens at all the other growth locations in the body. When we look at how the age distribution is on this, if we look at 2, where you have these separate ossification centers and focus in on those, you see it's very common in the age group of 15 to 20. And here we see 21, 25, 26 years old having these pieces of bone at the front. And I think definitely when I was back in Holland, I've misdiagnosed these people sometimes as having a degenerative or fragmented symphysis, while in fact this is a completely normal finding. And you can also see it on MRI, so I think, and on ultrasound. So I think there's some great opportunities there going forwards to try and find out when is this normal or pathological, what's the best way to image this, and the treatment. I think probably a different paradigm required, and that's what's in the article as well. Instead of strength training, unload them, get them pain-free, and then bring them back again, like you would do, I think, with all growth injuries. but it's just a very different age group. Here we're talking about the late teen period, early 20s. So again, very interesting and relevant work. The last member of the team, Magneto from South Africa, Dr. Paul, who's now involved in running the Doha study, the development of hip abnormalities. In Andrea's study, we talked about the cam deformities in the hip, this bump on the femoral neck, and a lot of the work also from Morpho Manrinche would suggest that perhaps these bumps are forming during the growth period. So in the teenage period, if people are doing a lot of sport, then they might develop these bumps on the neck of the femur. And again, here at Aspetar and Aspire, we have a unique opportunity. We have a large population of adolescent football players who are well cared for in the Aspire Academy. And we have a large population of adolescent swimmers. And this lays the ground for trying to find out if too much sport in this period could lead to you forming one of these bumps. Why is it important? Because these may lead to you getting osteoarthritis as an adult. So I think this is a real opportunity. On the one hand, we want to encourage people to have a healthy lifestyle and do sport, do a lot of sport, but there may be an upper limit, especially in the period when you're growing really fast. So an opportunity here, by doing a lot of magnetic resonance scans of the hips of these athletes as they grow, train and develop, to find out if you can have too much of a good thing, and if doing a lot of sport around the peak height growth velocity might lead you to develop a cam lesion. So a fantastic opportunity here in this setting to look at that. A movie always ends with credits, and I'd like to just take the time, as it's my farewell lecture, to thank some people. As you've seen, a lot of our studies from the Groin Pain Center involve radiology, and I'm very grateful for the opportunity that we've had to do so much imaging. It's pivotal to many of our research projects. So thanks to Dr. Nabil and the whole team, all the staff in radiology, for assisting us, because we've created a lot of extra work for you guys, and it's given us fantastic opportunity to do these studies. Thanks very much to the NSMP. I've seen NSMP grow hugely in the time that I've been here. It really is the rise of an empire. And without the interaction and the collaboration with you as NSMP, we couldn't do any research to help improve clinical care. It's only by having a good relationship with you guys that this has all been possible. So thanks to all of you for this. Thanks to the sports medicine team. I think as a sports doctor, it's a fantastic place to come, and you really feel like you've joined a special team. Yeah, Aspetar, we know it's fantastic. It can also be dynamic and at times crazy, and having a supportive and loyal team around you has been really important to me personally to survive at times and to continue having great fun and enjoying being here. So thanks to all of you. Also thanks to our support staff, the secretaries, Leonora, Rana, now Safir as well, Jensen, Dana. Thanks so much to all of you. May as well. You're the guys who, the people behind the screens who make everything run. So much appreciation to you all. A special mention to the Dutch Mafia. I was recruited via them, and we all live together on the same compound. So to you guys, colleagues, but also friends, and it's made it really special living and working with you all together here. Thanks to the senior management. Without real support from the senior management to support the, sorry neighbor. But without the support of the senior management to push these projects, none of it would happen. It requires continued support from senior management, the X-Men bosses, to make this all happen. So I'm very appreciative of the support I've had from senior management and for the centre while we've been doing this work, and I hope that continues. And thanks to everybody else. I didn't want to make a million slides, so I think to close, I've had a really fantastic and fun time here. It really has been happy days. I'd like to thank the entire Aspetar family for having a fantastic period here. So, shukran.